2, so second year, stage 2, and I'm just thinking of starting psychotherapy.
Yeah. Something to do with it.
Yes.
I'm Stefan, I'm stage 3, the start of stage 3, and I did already 55 sessions.
And when did you start your one?
So that's next.
My name is Vikas, and I'm first year is history, and I have finished 46 with Dr. Coleman supervising. So planning to start
Okay, fantastic.
I'm stage 3, so I'm finishing the section in about a month's time, and I've written a fair bit of the session.
Fantastic.
I'm James, I'm only stage 1, I haven't started this.
We just met.
Yeah. All right. And look, is there a library here where you're passing on cases that have passed? They go from generation to generation. That would be good.
I don't know. I never heard of it.
Okay, look, it'd be something to chase up the people that have finished training in the last couple of years and ask them for their case. So that there is sort of a library of past cases.
What a great idea. And it should be about a psychotherapy program. We should have perhaps have as part of our system of files in our library, Tony. That'd be
Yeah, no, we do. We recommend people do that on an informal basis. But
Yeah.
it would be good. I do get requests.
My understanding is there are people who have some past cases.
Yeah, we'll put the hard word on them to give you copies and you can give everyone else copies, or, you know, Greg a copy.
Yeah. It's good to have it in
Go
one
to a
spot.
photocopy.
And that cumulative knowledge and all the errors that people make along the way, and we could minimise it. I think that's definitely good. We have done it in the past, a long time ago. When I was in my incarnation over a decade ago, we collected case histories of all kinds, not just psychotherapy back then, and it was of great value. We passed them out to people. It's something we've kind of maybe stopped doing. We've done it informally, but why not? Why not accumulate all that knowledge for everyone to dig into?
Can I just ask a question about that? To be honest, I have some past one, but I wasn't sure if getting them or even passing it to other people was kind of legal or...
Oh, look, you can't take slabs of what they've written.
No, yeah.
Because if you're caught doing that, there'll be serious trouble.
Yeah.
But it gives you an idea of the structure, the way to present a case history, you know, the domains to use and things like that. And look, sometimes even a failed case plus the feedback given to that person is a good thing to look at. So you can read a case, see what you think of it, and then see what the examiner said about it.
So just let you know, we'll wait just 5 minutes to see if everyone rings through, then we'll, if no one does ring through, I'll just introduce you for and then we'll go on to our second.
Yeah. Look, the trainee group keeps on asking the college to put old exam papers and past psychotherapy cases on the website.
Yeah.
But because the psychotherapy cases are clinical material, the college has said no, and it isn't going to happen. And the trainee representative committee keeps on asking, and the college keeps on coming to the same answer. So that's why you need to do it locally.
I'm not sure if I can ask a related question. It's not to psychotherapy, it's just on that. Can we get previous scholarly projects from college?
I can raise that with them because
That's so new for us. Because the scholarly projects have been new, and so we don't have any idea really how it works.
yeah, the standard expected and things like that.
Yeah, because psychotherapy cases have been going on for some time still. The scholarly project is so new.
Yeah. Okay, look, I can raise that with the exam committee. It'd be up to the authors to actually consent to that, but I don't imagine many registrars being terribly embarrassed about their work being available through the college website. And are any of you likely to go to College Congress in Cairns in April, May next year?
I will probably do.
Okay. In the pre-conference workshops, there's going to be a scholarly project workshop. So that would be something to factor in. I'm also doing a psychotherapy, well, I'm actually doing this workshop there, but you won't want to go to that twice. And actually, for the psychotherapy supervisors, the psychotherapy markers get together once a year for a very, very short business meeting, and then everyone's given 3 cases to mark, and then as a group we discuss them, so that we're all on the same standard. I'm actually doing that calibration exercise with psychotherapists up in Cairns one afternoon before Congress. So if you were thinking of going to Congress, I am hoping it's going to be the Friday afternoon before Congress. And if you went there a couple of days early, I wouldn't imagine any difficulty with you joining that.
Yeah, I think Lloyd McLean's already been involved in it.
No, they do a different workshop. And it's about supervision and how to write a case. This is actually looking at marked cases and discussing them so you can get a really good idea of the standard.
Well, no one's run through, that's fine. We've got a nice little group here. Someone may ring through later. And I think there are 1 or 2 people still on their way, but I don't think we should wait any longer. I'd like to really welcome Andrew Pethebridge for coming along to Western Sydney. And Andrew, you look so comfortable in that position. I don't think you really want to go back to Eastern Sydney. We can capture you here.
Oh, I'm not getting up the M4 every day.
But it's a delight to have you here. We organised this really, so the first thing I did when I was acting director of training was almost the first week. I think you'd sent out an email just offering services, and I captured that interest in February, and I knew when September came around you started thinking, when is that date? So it's great to have you here. Now, Andrew, is your chair of the subcommittee in terms of...
The marking subcommittee.
Yeah, marketing subcommittee. And so I just thought in terms of the kind of rejuvenation and refreshing of training in Western Sydney, we've done many, many levels with OSCE's Paper 2, Paper 1 preparation, that this was a great opportunity to get someone of Andrew's stature and knowledge to tell you, from the horse's mouth, literally, how to get through. Because there are basically 5 hurdles you have to get through as a trainer from college perspective. 5 major ones. Paper 1, Paper 2, the OSCE, scholarly project, and this. Of course, there are many other smaller hurdles and so on. And my observation, Andrew, though I haven't been director for a long time, is that this is no gimme, that trainees do have to work hard at it. They need proper supervision and proper feedback. And I'm hoping you'll be able to shine a light on a way for our trainees to perhaps have improved performances and not have to resubmit cases.
Yes.
Thank you very much for coming.
That's
really
fine.
appreciate it.
That's fine. Look, I'm happy to help. And the one thing you need to know about me is when I actually start talking, I don't stop. So if you have a question, wave at me, do something, because I'm happy to stop and answer questions. And in my other life, I'm the Greg equivalent in southeastern Sydney. So what I want to do is tell you about the case history and what I think you should be doing from go to woe, tell you a little bit about what happens behind the scenes, and then to actually discuss what examiners look for in cases and what will fail you. All right, so from the outset, submitting a written case can be a little bit like this picture. Each of the bits make sense, but put them all together it doesn't. And hopefully after I finish speaking, it will make sense. And if any of you have heard of Tom Lehrer, he's a wonderful American actually mathematician. And he released a number of records of comedy songs. So one of them was the Boy Scout song. And the chorus was "Be prepared." It's the Boy Scouts marching song, "Be prepared as through life you march along." And that's really what you have to do with this case. So how do you prepare yourself. Look, first year, you're really busy, just getting on top of psychiatry, getting on top of everything that's Hetty's teaching you, getting to understand illnesses and DSM and all the rest. So don't worry about psychotherapy. But somewhere towards the end of your first year, when you feel that you're coping with your day-to-day work, that would be a good point to come to some of the psychotherapy supervisors and say, can I sit in on some of the therapy sessions? And if that's irregular, not ideal, but that's fine. But once you actually start therapy, the difficulties you encounter are going to be exactly the same as the difficulties everyone else has encountered. That's all right. I'm glad you're here to do the technology.
Let's grab a seat.
So I'll give them 30 seconds to phone back. But anyway, start gate crashing supervision because you actually learn a lot from that. And I presume the supervision you offer here is a small group? Or is it one-to-one?
Sometimes one-to-one, sometimes two in a group, yeah.
Yeah, okay. And again, look, the idea of having a therapist and having, an hour of their time every week is absolutely wonderful. It's actually, I think group supervision is probably a little bit better because you can hear from one of your peers what's going on in their therapy, and they might encounter things that you don't in your therapy. And so it's good to hear about it and how to approach that. And hello, is that Westmead? We can't see you, but I saw a hand waving. Hi. Are you able to see the slides? We get a thumbs up or thumbs down? No? All right, did you know how to see the slides?
Yeah, I'm trying to do this. This is unusual.
I think it's Russia, I can message him.
Yeah, it's Russia.
So where is Russia at the moment? She's here, isn't she, in Westmead? She can almost come over, really.
Yeah, she had a patient and she's lonely. Can you hear us, Russia?
Okay, can you hear me now?
Yes.
We lost the slide.
Okay.
Have you tried this presentation?
Sorry about that.
Yeah, we lose it after presentation.
I think we have one of two options, guys. So Santosh, I think we either get Russia to come over, because she's only just really on this campus, or secondly, we get back to the slide, which we all need here, because most people are here, and Russia could maybe just hear what we're saying. That's the other thing she wishes to say.
Yeah. Russia, there's a technical issue with showing the slide here. Can you see the slide there?
I can, yeah.
Can go there.
Now.
It's one person versus 20.
Can you reverse your screen?
If we put on the slides here, you might just speak and let us know if you can hear us at least.
Can we put on the slide here, Santosh?
Yeah, they have to, but they're going to have to terminate the call there. I'm not sure why we can't see it.
They've disappeared again though.
Okay.
They come on and then they go off. I don't know why.
So let's make a decision. So Russia, it's Greg Demore. I don't know if you can see me or hear me. Can you hear me? So,
Yeah.
Russia, we've got a problem with the technology today, unfortunately. So we have two options, or one option definitely is, if you can come over, because you're on the Westmead campus, but just...
Yeah.
So, she can't come over?
Yeah, she said she's alone there.
I'm the only registrar here, but now that I've got Peter on the ward, I might seek permission. Would you be able to wait for me till I come down?
Well, we might...
Or do you want to just get started and I'll come down?
I think we'll start, and if you could come down, it would be great.
All right.
Sorry about that, Russia. We weren't expecting this technology problem, so I think that's what we'll
No,
do.
I'm so sorry.
Okay, no worries. Okay.
We'll see you shortly.
Thank
See you
you.
shortly. It's in about 5 minutes, 10 minutes. Okay.
Bye.
Okay, so we might just, so Josh, is there some way we can stop calls coming through just so we don't get that issue again?
Yep.
Okay. Andrew, sorry about that.
That's all right.
But it has been my bitter experience that technology promises a great deal,
Yeah.
but rarely delivers. Unlike psychotherapy.
Yes. All right, so somewhere late in your first year, start sitting in on psychotherapy supervision, and then hopefully you're learning a little bit about psychotherapy in your general reading and in your coursework here at the head of training. And then when you feel ready in stage 2, I don't know what the system here is for finding a patient. Is it coordinated through therapists, or do you just do it informally through your various networks?
Tony, I think would be the best person.
Yeah, look, I mean, people do find their own patients through the local networks often, but if they're having difficulty, we can usually help them centrally as well.
All right, so look, when you feel ready, let your peers know that you're looking for a patient. If any of you have friendly GPs in the neighbourhood that you know, chat to them, because they're often a great source of what used to be called neurotic patients. The patients that you actually don't see in mental health services anymore, and they're sort of the perfect people to take on for psychotherapy. Let your fellow registrars know. CL's a great place to find suitable people. Child and adolescent is also a great place, not for the adolescents, but actually for the parents. There'll often be a mother or a father that the registrar thinks, you know, the parent might be suitable for psychotherapy. Often acute care services will come across someone in crisis who settles down fairly quickly, and again, they think that psychotherapy may assist them. But whatever you do, never rush taking on a patient. Never sort of think, well, I've got to take a patient, I've got to do it, and it's got to happen, I've got to start it this week, or my whole training program is going to be out of kilter. And never take on the person who's, the patient who is happy to label themselves the worst borderline in the service. Someone like that certainly needs psychotherapy, but they need a very experienced psychotherapist. What you want is someone who's going to be reliable, who's going to be able to come every week at the same time to the same place, and over the course of, you know, what is in effect very brief therapy, is going to show some improvement or some change in their symptoms. You know, you really, this is your first time doing psychotherapy, so you want a nice patient, and you actually want to see a success in the course of this therapy, and most people do. The other thing to be very, very cautious of is an assessment for psychotherapy is very different to the sort of assessments that you do after hours. You know, you've got an hour and that's it. You're going to spend 4-7 hours doing your assessment of this person. You're going to know them in amazing detail. And after you've spent 4 hours with someone, if you're thinking, I don't like them, don't take them on for therapy. Therapy, we talk about a therapeutic relationship. You are going to be spending an hour a week with this person. And if after 4 hours you really don't feel comfortable with them, it's like a bad marriage. It is not going to be a pleasant exercise for you. But if after 4 hours you're thinking, I like you, I think I could help you, then yeah, that's the sort of person that you'd want to take on board. So at least the relationship is starting off on a positive note. Yeah, never take on someone because you're desperate. Look, significant self-harm. And, you know, here I'm talking about someone who will make 3 ED presentations in, 6 weeks. That sort of person, yes, they need support. Maybe you're not the right person to do that. And look, what's also very useful in your write-up is to have a patient with a subset of symptoms that you can actually describe in your case, and then at the end of your case you can actually tell me, this is what happened to their symptoms. And that symptom might be their relationships, it might be their mood or their anxiety, it might be their functioning at work, but have something that you can sort of measure and discuss in the case as a sort of before and after. So now, what's required? It's weekly therapy sessions. So you have to be able to commit yourself to seeing the person every week. You can't do it fortnightly. If it is indicated, yes, you can see them more than weekly. You can see them twice weekly. You can see them 5 times a week if you want. But it has to be at least weekly. And in the old bylaws, there was a loophole where you could actually see a patient twice a week over a 6-month term, do your 40 sessions and you were done. That loophole's gone. You now have to see the patient for at least 6 months, which means 7 months of therapy. So if you see them twice a week, you're seeing them for at least 7 months. You will need a clinical supervisor, so that there is a clinician somewhere in the service that you need to report to and tell them how the patient is going. And if everything falls apart, there is a clinician who will be clinically responsible. Your psychotherapy supervisors are there to support you in your therapy. They're not there to take clinical control of the patient. They're there for you, not the patient. Now, who here would ever do an assessment of the patient, decide they're psychotic, decide that olanzapine would be an appropriate medication, give them a script of olanzapine and say goodbye? No. Good. With this psychotherapy case, what the college says is you have to do basically a year of therapy. In a year of therapy, you're going to have a month's annual leave. The patient might have some annual leave. You're going to get sick in the middle of winter and they're going to get sick in spring. So that works out to be 40 therapy sessions. But you're taking this patient on for therapy. So that means at the end of 40 sessions, you decide you discuss with the patient and your supervisor whether therapy should continue. Because sometimes taking someone to 40 sessions and then saying, okay, we've done our 40, goodbye, farewell, is a bit like writing a script for olanzapine and saying, here, take this, goodbye. It's not therapy. You are not writing you are writing a case as a college assessment, but you are entering a therapeutic relationship with the patient, and the expectation is you will offer a course of therapy, which might be 50 sessions, it might be 3 years of therapy. And sometimes people have gone from psych training into private practice and they've taken their patient with them. And that's fine. Now, when it comes to the case write-up, you have to talk about termination. And you can't talk about termination if it hasn't happened. What you can, though, do is discuss how you will terminate this patient. I know that this patient will be ready to terminate when this has happened with their symptoms, or when this has happened with their index problem that I identified at the beginning. So, when their relationships are doing this, when their function at work is doing that, I know they'll be ready to terminate. And I will terminate by giving them 3 months' notice and continue to see them every week. I will terminate by giving them a month's notice and see them fortnightly, so see them 2 more times. You know, I will see them fortnightly for 3 months and then monthly for a couple of times and then terminate. Whatever you feel will be indicated and appropriate. And so talking about termination in the theoretical will be entirely appropriate. Now, if there is anything out of the ordinary, there is a loophole, but you have to go to the college and ask for permission. And who you write to is the Committee for Training. So, look, there was a case where a patient disappeared after 36 sessions. And the registrar phoned up the patient, wrote letters, may or may not have made further appointments, but the patient never turned up. Rather than being brutal and saying, you haven't met for 40 sessions, go back to the beginning and find a new patient, write to the Committee for Training. And I can tell you that in that case, where the trainee had done 36, 37 sessions, the Committee for Training said, okay. But the expectation is, in your case write-up, you will actually discuss that. You know, what do you think was going on for the patient? Why did they disappear? And what was going on for you? How did you deal with your anxiety, being worried that I'm going to have to pick up another patient and do a year of therapy? So that's part of the structure of what you can write about. If you're sent out for a rural term and want to do supervision by teleconferencing, if you want to do a few patient sessions by video conferencing, you need to write to the Committee for Training and actually ask for permission for that. And again, write about that. What was it like doing some video sessions? Was it as good as face-to-face? What was it like dealing with your supervisor over the phone rather than in person? How different was it? Was it still helpful? If you're going to have annual leave of 4 weeks, or the patient has 4 weeks leave, that's fine. If there's going to be a break of more than 4 weeks, again, you need to write to the Committee for Training and tell them there's going to be this break of more than 4 weeks. You know, is that all right? And they're going to rubber stamp that. But again, look, if you have a 6-week break in therapy, that's quite a break. And again, we'd expect you in your case write-up to say, we had this 6-week break in therapy, and when I got back to the patient, it was different. You know, and how was it different? And maybe hypothesise why the relationship seemed to be a little bit different. And anything that the college says you need to do is 3 workplace-based assessments through the course of therapy. 1 in the beginning-ish, 1 in the middle-ish, and 1 towards the end. And the idea is you sit down with your supervisor, and at the first one you actually discuss, is this patient suitable for psychotherapy? Why not? You know, what are the prognostic factors that are good? What are the poor prognostic factors? Somewhere in the middle, you actually discuss what's going on in therapy. What are the transferential and counter-transferential feelings that you're having? How do you actually sustain a relationship like this for a year? What's going on? What's difficult for you? And towards the end, you discuss termination. Now, the college isn't asking you to do these WBAs because we like WBAs. We're asking you to do them because this is a really great idea to point you in the direction of what to write in your case report. Your supervisor can pick up on the key themes about this patient and really blatantly bring them to your attention. So those exercises are really, really helpful. Now, the only thing you need to know is in your day-to-day work, WBAs can sort of carry across consultants and carry across terms. These 3 WBAs are specific for the patient that you do the write-up for. It is very, very common that people will take on a patient, 12 weeks into therapy, they drop out and disappear. And you have to pick up a second patient, or, sometimes a third patient. With each of those patients, you need to do a new set of WBAs. And those 3 WBAs are submitted to the college with your written case. Now, what I suggest is about session 10, actually start to write your case. And just get all that historical information down on paper and put it aside and forget about it. Then, at around session 40, pick that up and finish writing it. The reason to do it in 2 steps is because when all the historical stuff is really fresh in your mind, it's easy to write. If you do your therapy sessions, then come back and write the case in its entirety, you might not be able to read your old notes if you're at all like me. And there is also this really strong temptation to flesh out the history with all the information that you'll learn during the course of therapy. And you make the case have an absolutely brilliant, detailed, thorough history. Yes, that will be great, and you'll be able to do a fantastic formulation. But then when I read it, I won't see any progression. I won't see any revelations during the course of therapy. And your reformulation will fail because you have no new information to give me. So if you've already written your initial history and your initial formulation, great. Your reformulation hopefully will be very, very different. And at that point, don't worry about word limits. Give your case history to people to read. Certainly your psychotherapy supervisor, any of the Scots here that you're friendly with, Greg, if he's weak enough, said yes, I'm happy to read it. Any consultants that you're friendly with, give them the case and get them to give you some feedback. But I would suggest you actually don't worry about that feedback. Sort of get it all together and put it aside and have a cup of tea and relax and actually read a good book. And what I'd suggest is an Agatha Christie. Agatha Christie books are really small, they're really thin, you can read them over a weekend. And they are delightful. Don't cheat, don't watch any of the TV shows, don't watch any of the movies, because they're not true to Agatha Christie. What Agatha Christie does, and does it beautifully, is in that first 2 or 3 chapters, she presents you all the evidence for the murder. And then in the last 2 chapters, she brings it all beautifully together, and you have that aha moment. It all falls into place and it all makes sense. So if you have a busy weekend, looking after kids or whatever, just read the first 3 chapters and the last 2 chapters. You don't even have to read the whole book. But what Agatha Christie does is she gives you this single narrative and it flows and it all makes sense. And that's exactly what you need to do with your case history. It's not quite a detective novel. Well, no, actually it is. Your case is a detective novel. You're giving information, you're giving historical information about this patient, their symptoms, their life and their illness. You're doing a formulation, therapy, and then your conclusion, which is your reformulation. And that has to be a single coherent narrative, a single story. So you tell me all of this historical information, and then you do an etiological formulation where you take all the historical data and make sense of it. With your etiological formulation, when I'm reading it, I want to say, yes, you told me about that in the history. That makes sense. And when I read your diagnostic formulation, I'm saying, yes, everything in the etiological formulation points to that diagnosis or those diagnoses. And then with those diagnoses, and again, with your etiological formulation, your management plan will make sense. So let's say in your formulation, you're telling me that this person has an unresolved Oedipal complex. Let's be really old-fashioned and Freudian about it. When I'm reading that formulation, I'm thinking, your management is going to be classic analytic psychotherapy. And when I read that in your management plan, I'm thinking, yes, that's a coherent single narrative. But in your formulation, if you're telling me about an unresolved Oedipal complex and you're going to offer this person self-psychology, what I read is a disjunction. The evidence doesn't make sense in the context of the end. If you're going to be offering self-psychology, then your formulation needs to tell me about this person and their relationships and their interrelatedness and why they're having difficulties with relationships, which might be attachment difficulties. And so to do that in reverse, if your formulation is all about attachment difficulties, mum having postnatal depression, dad being an alcoholic bully, and your management plan is about self-psychology or object relations or even mentalisation, that I read as a single coherent narrative. But if in that case your management plan is about doing Jungian therapy, again, that's a disjunction that doesn't make sense. Now, where you're allowed a disjunction is actually in the course of therapy. Just because you've written in your management plan, I'm going to do self-psychology, and 15 sessions in, your relationship with the patient isn't working with that model of therapy, and your supervisor is suggesting, let's do something different. As long as it's not cognitive behavioural therapy, that's fine. Your management of this patient needs to be responsive to the patient. So you don't persist with a particular model of therapy if it's not working. And that's what you write about in your reformulation. And it is very, very appropriate to say, in my reformulation, my initial understanding of this patient was about attachment and object relations. But during the course of therapy, my understanding of them evolved, and I had this different understanding. And yes, mentalisation was an appropriate therapy. And that the course of the second half of therapy was very different because I took on a different model of understanding the patient and a different way to interact with them. That is perfectly appropriate. And again, it's a bit like starting someone on a FRANZCP who comes to see you a week later and they can barely stay awake in your appointment. And you think, maybe my medication is sedating them too much and I'll give them something different. If your therapy isn't working, give them something different. But one of the big reasons cases fail is the management talks about dynamic therapy and actually doesn't talk about a model of therapy. You actually need to talk about a specific model of therapy. Saying, I'm going to give this patient dynamic therapy is a little bit like saying, I'm going to give this patient an antipsychotic. A medical student can say, I would give this patient an antipsychotic, and they'll pass their exam. But you, as psychiatrist, remember, your case is going to be marked with the junior consultant standard. Dynamic therapy means a lot of different things. And you need to tell me what sort of dynamic therapy you're offering. Now, what's the expressive?
Expressive supportive.
Expressive supportive actually counts as a dynamic therapy. We're happy to accept that. Mentalisation, we're happy to accept as a dynamic therapy, but we'll actually be looking at the course of therapy. Mentalisation can also almost be like a CBT exercise. And if your course of therapy is a bit like, you know, I told the patient, let's mentalise, you know, this other relationship. What do you think's going on in their head? And you direct them like a behavioural therapy. That's not a dynamic therapy. Schema therapy is not dynamic. Adapting interpersonal psychotherapy is not dynamic.
Conversational model?
Conversational model, absolutely, yes. So, you know, just make sure you are doing something that's dynamic and that you identify and tell us what it is.
So in your discussion, actually you need to justify why you use this model, specific dynamic model.
Yes, but because of your etiological formulation, that will justify. So in your management plan, you'll just say, you know, my formulation noted that this person has relationship difficulties, attachment difficulties, and so I'm using the conversational model, I'm using object relations, self-psychology, however you'd like to label it. All right, now, hopefully you'll have a draft of your case somewhere around the end of year 3. And, a draft of your case around year 3. You give it to a group of friends to look at, and read your Agatha Christie, and keep that case aside for about a year. And start mapping out stage 3 of the training. When you're going to do your essay, your OSCE, and what you actually need is a bit of theoretical maturity around psychotherapy. So you actually want to finish your formal education course, you want to do some reading about psychotherapy, and then you want to pick up your case again and reread it and correct it in the light of the word limit, all the feedback you've received, and your junior consultant understanding of what dynamic therapy is all about. Plus, you want to read it in light of the marking pro forma. What I, as an examiner, mark you against is on the college website. There are about 30 domains, and if you can tick off that you have done all 30 of those domains, bingo, there's a really good chance you will pass. But if you run out of words and you skip a couple, there's a really good chance you're going to fail because you didn't do those marking domains. So look at your case again, in the light of all of that. Give it to your psychotherapy supervisor, anyone that you're friendly with, and get them to read the final case. And then submit it. Now, you certainly need your signature of your psychotherapy supervisor before you can submit. And we actually do a survey each year of people that have submitted a case. And we ask them, how long did your psychotherapy supervisor have to read your case? Somehow or other, there's always 3 or 4 people each year who didn't give it to their psychotherapy supervisor, but somehow they got a signature. And then there's a comfortable 15 to 20% that gave it to their supervisor for 2 or 3 days. And that's like giving it to them on Monday and saying, look, I've got to post that on Thursday morning to get to college by Friday. And honestly, look, that's a complete waste of time. Give it to your supervisor and tell them you've got 2 weeks to look at it, and then can we sit down and over a cup of coffee, you know, tell me what the case is like and what I need to change and correct. And then give yourself another week to make all those corrections, then submit your case. What you want to do is submit your case, get it marked and pass, and then you move on. If you want to rush the process because the deadline is, at the end of this month, and you've got 5 days to do it, and like every other registrar, you don't do anything till the last minute, yeah, look, submit it, but don't be surprised when you fail. Give people the opportunity to support you and help you. Right, now, what goes on behind the scenes? First off, every marker is buddied. So there are pairs of markers. And your case will go to a marker, and generally someone not in New South Wales. They will read your case. They will mark it against the pro forma, and if you've passed, that's it. That's the end of the story. You've passed the case. That's over and done with. If you fail, it will go to the buddy marker, and they will read it, and then the 2 examiners will have a discussion or email backwards and forwards, and if they can together decide that the case is a pass, then it will pass. If they decide that it's a fail, then it will fail. And if they can't decide, the case will come to me as the chair of the committee, and I get to read it and I'll decide whether I'll agree with the person who said pass or fail. If you fail, there will be feedback coming back to you, and that will be half a page and a half, 2 pages of feedback, and you will then be invited to resubmit the case in the light of the feedback. And if you don't understand the feedback, bring it to your psychotherapist, bring it to Greg, or if you really don't understand it, write back to the college committee and the examiner to give you a little bit more feedback. But respond to that feedback, resubmit. Your case will then go back to the original marker, and they'll be given your first submission and your second submission. They'll read your second submission. If they say, yes, you've responded to all the feedback, and I'm happy with it, it passes. Now, if on their second reading, they pick up something that they didn't pick up on the first time, that they don't think was up to scratch, they can't raise that as an issue to fail the case a second time. They might provide you feedback saying, on my second reading, I've realised that there were difficulties with your mental state examination. That will be formative feedback to you. It won't be something that will fail the case. If you've responded to the feedback, it will pass. But anyway, so your 2 cases will go to the first examiner. They'll read it, and if they've said you've responded to the feedback, your case will pass, and that's the end of the story. If they think it's failed, it will again go to their body examiner to read. The 2 of them will discuss, and if there are difficulties, it will come to me for arbitration. Again, if you fail the second time, we'll be giving you feedback, invited to do a 3rd submission, and the 3rd submission with the first and second submission automatically comes to me as the chair of the committee. So I will mark it, and the way I do that is by reading the 3rd submission as if it was a first submission. And I will look at any difficulties that I find in it, then I go back to the feedback. And if I've discovered something new, then the case is a pass. And I might give you some formative feedback. If I think the case is still weak on an area that's already been identified to you, then yes, you'll fail the 3rd submission. If you fail the second submission, you actually do need to meet with Greg and do a targeted learning plan. So at least Greg's going to read your case again and point you in the right direction for your 3rd submission. And again, secret examiner's business, as I mentioned at the beginning, once a year all the examiners get together, we have this very short business meeting, and then a couple of weeks before the meeting, everyone's given 3 cases. Generally, a case that kind of just passed, a case that just failed, and a case that was a clear fail. And everyone's asked to read them and mark them without knowing which case was which. And then as a group, we spent an hour and a half, about an hour and a half, discussing each of those cases. The idea of that is that all the examiners are on the same page, we know, we've got the same standard that we're looking for. All new examiners are given a training package, which includes a couple of cases and the feedback for those cases.
Andrew, can I ask you one question?
Yeah.
You said when the third time you submitted, if it is failed, it is failed. You need to start a new case, is that right?
It'll go to the committee for training and they'll make a decision. They may allow you to do full submission.
Oh.
But you'd have to justify why that should be. Yeah. Right, so what are you required to do? All right, now you need, as I said, a clinical supervisor, and that's a clinical relationship. And the college doesn't want to know about that relationship other than that it exists. If your clinical supervisor actually wants to meet your patient, fine, that's up to them. If they just want an email from you every 3 months, that's terrific. That's all they want. It's a treating relationship. And so it's the parties involved in that relationship that define what's required. But you do need a clinical supervisor. You need to see them at a minimum after every 2 therapy sessions. So if you're doing therapy twice a week, you need supervision every week. If you're doing the more classic therapy weekly, yeah.
Sorry, is it the clinical supervisor we need to see every 2 sessions? Or
No,
is it
the psychotherapy supervisor. So, seeing a patient twice a week, you have supervision every week. If you're seeing your patient more classic weekly, you really only need to see your supervisor every fortnight. But this is probably the only time in your life when you're going to be with an experienced psychotherapist for an hour, alone or sharing it with one other person. You actually want to really make the most of this relationship. At the end of the process, most people really enjoy learning about psychotherapy and actually doing it. And usually you get a patient that kind of changes over the year. And you actually see that, and it's a really exciting process to be involved in. And actually see that talking with someone changes them. It's amazing. It works. And that's why we've been doing it for a century. So what was I going to say? So while you might see your patient weekly, and you only need to do supervision fortnightly, do supervision weekly. Make the most out of this experience. Your clinical supervisor, and Group Demore are not going to be jumping up and down saying, you can't see your supervisor every week. So make the most of this experience. And they're there to teach you and guide you and help you. And so make the most of that experience. All right, now, your written case. As I said, you need to discuss why this patient is suitable for this therapy, the model of therapy you're going to be using, and your formulation is going to explain, the complex meanings of the symptoms, behaviours and motivations. When you go through the Martin Pro forma, words like breadth of reflection, experience, maturity, reflection are key words. And again, in reading these cases, we are very aware that this is your first time doing psychotherapy. We are not expecting you to be experienced therapists, and we're not assessing you on that. We're expecting you to do stupid things. Please write about that in the case. Because we can actually see what you learned. If you tell me that I was brilliant and the course of therapy was beautiful, I actually don't see you in that. So let me know what you did wrong. You're not going to fail because of that. Yeah. All right, so now, it is a summative assessment, it is something you can fail. If you haven't passed your case by the end of 5 years, you're going to get a letter from the Committee from Training saying, why have you not passed your case? And you need to respond to that appropriately and quickly and explain to them when you are going to be submitting your case and or when you are going to be passing your case. A letter like that from the Committee for Training, if you ignore it, fairly quickly thereafter you'll get a letter from the Committee for Training asking you to explain why you should continue as a trainee. And so this process and the deadlines are treated very seriously by the college nowadays. As I mentioned, the case is marked at the junior consultant standard, but we're not marking your therapy, we're marking your writer. Minimum 40 sessions, 3 workplace-based assessments. Now, you can actually submit your case to the college whenever you want, but there are 4 marking cycles a year. And, you know, when the college says the deadline is the 1st of March, it is 5 p.m. on the 1st of March. If they get your case arrives 9 o'clock, you know, the Monday after, it will go into the next marking cycle. But again, don't aim for an absolute deadline. Aim to get your case right and ready to pass and then submit it. And if you fail, if you miss a deadline, big deal. You know, there's going to be one in 3 months' time.
Just to clarify, when we say minimum 40 sessions, it includes the 4 or 5 assessment sessions?
Yes. Now, as I said, there are about 30 marking domains, or 30 marking measures, but there are 7 domains. And they are presentations, assessment, management plan, clinical progress, reformulation, supervision, communication, liaison, discussion, and how to fail. Okay, now, last year, 115 cases were submitted, and 64% of them actually passed. What depressed me is that of the 41 cases, a majority failed across a lot of areas. People very rarely make mistakes in one area. In fact, only 2 people failed in one domain. 7 people failed in 7 domains. 11 failed across 4 domains, 4 or more domains, and 6 failed in 4 domains. So, where are we? 24 people, more than half, failed for at least half of the marking domains. And again, I worry about people like that. They were working to a deadline, they didn't read what they were doing, they didn't submit it to people to look at, and they didn't look at the mark sheet and look at what we are looking to assess. And last year, 2 cases still failed in de-identification.
How many of them pass in the second attempt and do it?
I've got that.
Is that, sorry, the identification like the simple name, addresses, phone numbers, or is it just like enough information that you'd be able to?
Yes. So look, the first, it was a few years ago now, but the first identification was a patient whose hobby was a career. Her age was given. She went overseas to do a master's degree in her hobby, and the case gave her age, de-identified her name, said what city she lived in, said what American university she went to, and what her hobby was. And I Googled all that data, and I got a photo of her. And she would have been quite happy to enrol me in classes in her hobby. She was a musician, and she would have been quite happy to teach me her musical instrument. And her website mentioned her going to this American university, the degree she got. And from the photo, she looked the right age. So, de-identification is generally fairly gross like that. But look, 1 in 5 people failed in that assessment. And I'm going to go through these domains and the sort of things you need to write about. Reformulation, again, 1 in 5 failed, and then fewer people failed. Management plan, regression, discussion, supervision, CL, and the presentation. Now, of the cases last year, first submissions, 63% passed, and was 70% of second submissions and 100% of the 1/3 submission. And over time, this is what's been happening graphically. And if you just look at the blue line for the moment, which is the total submissions, look, in 2014, 2015, there was a lot of fear that the psychotherapy written case was absolutely impossible to pass, and the standard was ridiculously high. People that submitted their case in 2015, and remember the new training program started in 2013. So by the end of 2015, you had people who were actually at the end of their second year. To present your case by the end of second year means you started your therapy in first year. And we are marking these cases as if you've done 5 years of training. And there's no way that you can expect someone in their second year of psychiatry to even have a vague idea of what it's like as a junior consultant. So yes, a lot of those early cases failed, but it was because people were unprepared for the standard. And when you look at the last couple of years, where people are submitting, I presume, in sort of their 3rd, 4th, 5th year, you're getting pass rates at, the 60, 70%. And I see no reason why it shouldn't be, 80%, and that's the kind of figure I think would be sensible. Same graph with first submissions, second submissions, and third submissions. All right, now going through each of the domains, it's not quite a domain, but you can actually fail if your English is atrocious. And certainly do a grammar check and a spell check on your computer. I have had cases submitted that they haven't even done a spell check. And it takes 5 minutes for 10,000 words. It's ridiculous. One thing that can be difficult is actually overly de-identifying people. And it gets kind of confusing. So you only use an asterisk to de-identify when you are lying. So you won't give me your patient's name. You'll give me an alias. You have lied. So you will asterisk that as a de-identification. You will certainly not tell me anywhere that you saw this patient at Cumberland Hospital, because they were clearly identified. But if you say, I saw this patient at my hospital, that's not lying. So you don't need to asterisk it as a de-identification, because you're telling me the truth. But when I read a case and I read hospital asterisks, the first question I'm asking myself is, this patient didn't see you in a hospital, so where the hell did they see you? And maybe that sort of situation is not so critical, but let's say you've got a Vietnamese-born patient, or someone of Vietnamese descent, born in Australia. And if you say they came from Southeast Asia, that's not a lie. So you don't need to put in an asterisk, because yes, their descent is from Southeast Asia. But if you write Southeast Asia asterisk, that tells me you lied. That patient was born anywhere in the world apart from Southeast Asia. Do you understand the dilemma that you've put me into? Because the way someone from South America responds to illness is very different to the way someone from the Mediterranean illness responds to a psychiatric illness. Is very, very different to the way someone from Southeast Asia responds to an illness. And in fact, someone from Vietnam may respond very differently to someone whose descent is from Canton or Japan. And so it can actually be helpful if I know this patient actually came from Japan or Brazil. And Brazil is big enough that you don't need to de-identify it. You can tell me this person came from Brazil. There are lots of people in Sydney with Brazilian descent. So I'm not going to be able to Google them and find out who they are. Unless they're someone rich and famous. You know, a diplomat, the child of a diplomat. Someone that's been on a reality TV program. Someone like that, you may want to actually de-identify their country of origin.
It can be tricky with artists if I want to use a quote, for example, of one of the lyrics.
Sorry?
If I were to use a quote from one of the lyrics which could explain something, you could Google it and you could know the name of the artist.
Yes.
So I should not use it.
Not use it, yeah. That could identify them.
It means we can put the culture background until unless they are high famous people, we can put the culture background. Because I was wondering, like, if we identify the cultural background in the country, sometimes the formulation is misled because we can't put the formulation properly.
Because, as I said, different countries respond to illness differently. And so knowing this person is from a certain country, will actually make your formulation that much richer.
What about the age? Because you said the age should be de-identified as well. No. Okay.
You know, whether they're 30 or 31 really doesn't matter. And I'm not going to be able to Google someone on the basis of their age, you know, or in Brazil. Or I can, but I'll get hundreds of people, so that's fine. All right, and now, one thing that really bugs me is people that write their case as dot points. You're actually, if you ever read a case in the published psychiatric literature, or even the MJA, read a medical case, they write English prose. They tell a story in paragraphs and sentences. You might do an after-hours admission here at 2 o'clock in the morning, be really, really tired, and you might write your admission notes as a series of dot points of episodes and incidents. You know, that's appropriate after hours. That will actually fail your written case. One, dot points are not formal written English. Even if you write them as paragraphs, it's not formal written English. You will also fail because of this example about Jane Doe is literally lifted from a case. The first paragraph in the developmental history, Jane Doe was born at term of vaginal delivery. The second paragraph, Jane was the middle of 3 daughters. Next paragraph, Jane's father was a violent alcoholic. Next paragraph, Jane was sexually assaulted at 12 years of age and again at 16 years of age. And it went on like that. Just a series of facts. Now, that case also failed in the formulation because just because someone was sexually assaulted at 12 doesn't mean anything. How did Jane respond to that sexual assault? How did her behaviour change? What happened? Did she tell her parents? Did they find out? What did they do? What did they say? What was their reaction? It's that depth that you need to be actually able to do a formulation. And again, a formulation isn't just a statement of a series of facts. It's an explanation of how those facts fit into this person's character and their ways of coping with difficulties. And another thing that I actually hate doing is failing a case because your references aren't done correctly. But again, it's not correct English, certainly not scientific English, and you will fail your case because your references aren't stylised correctly. Look, I've used EndNote. It's a beautiful computer program, a bit clunky, but it works well. There are two programs though, Mentally and Zotero. I've never used them, but they're actually free. You can download them and they will do your bibliography and they will format everything perfectly. So use programs like that. It will make your life so much easier. And the other thing I want to say, and I will deny that I said it, look, I presume a lot of you, English is your second language, and so this can be a really, really difficult hurdle for you. Unofficially, I have absolutely no difficulty with you Googling. It's the Society of Editors or the College of Editors in Australia, and there are people whose job is as editors, and you can search medicine, and you have 3 or 4 people up who have said, I am happy to edit medical work. That's my area of expertise. It's incredibly cheap. They charge you over thousands of words. Look, send them your case and they can actually help you with your English and see that it makes sense. Formally, the college says this has to all be your own work. But unofficially, I don't care if an official editor has seen your work. All they're going to do is correct your English. They're not going to correct your psychiatry. They're not going to tell you this really isn't judgment. Your understanding of insight is poor. They're just going to check that all of your sentences make sense. And I'm really happy with that. But again, in front of the college, I will deny that I told you that. All right, now, how do you fail the assessment section? By not giving me sufficient detail. And again, the Jane Doe example. Facts aren't enough. Tell me about this person. They had a very interesting life. Tell me their life story. Tell me about the relationships they've had, what went wrong, and give me sufficient detail. A lot of people with the presenting history like to break it up and either give me, the patient's history, mum and dad's history of the patient's illness, the GP's history of the patient's illness. What you need to do is give me a single chronology. So you need to integrate what the patient told you, the different story from the parents and the different story from the GP, and give me what you think the truth is. Similarly, some people want to give me the history of the depressive illness, the history of the anxiety illness, the history of the PTSD. The history of the presenting complaint is a single chronology. And I want to know over time how each of those illness syndromes have affected each other. What came first, the PTSD or the depression or the alcohol? And so give me a single chronology. And again, work forwards through time. So the history of the presenting illness will start, 2 years ago, 12 months ago, this event happened. 9 months ago, this happened. 6 months ago, this is how the symptoms evolved. 3 months ago, 2 weeks before I saw them, there was the crisis. And do it that way.
Let's suppose if a person had depression and they were hospitalized for whatever time and they improved. Now after 6 months of that, the patient has been referred to us, or after 1 year of that, we start from that depressive episode as well.
Yes.
In the history of presenting a play.
So go back to that sort of index episode. And look, when I read that, what I want to know, was there a crisis that led to the episode of depression, or it just came out of the blue? And I'm going to want to know enough symptom detail so that I know that, yes, you're talking about major depression, or are you talking about depression as a symptom? And then all I want to know is the name of the medication they were put on, or what therapy they had or ECT, any relevant negatives, and then you move on from there. You know, I don't want to know all the ins and outs of their hospitalisation, how many times they were in seclusion, and things like that. Just broad picture, what happened during the admission, and then what's happened subsequently. You also need in your assessment section is to tell me about physical examination and investigation results. And there is no such thing as routine investigations. So you actually need to, because what you think is routine may not be what I think is routine. So I recently read a case of someone in their 70s who had a cancer. And for me, a routine investigation is a head CT. You know, do they have secondaries? But for the trainee, they've just listed routine results. And I don't know whether that means head CT or not. So that's a fail. Now, I don't want to know all the numbers and all the results. I don't want to know their sodium and potassium. So list the tests done and tell me everything was within normal limits. That's terrific. But again, if there's anything abnormal, let me know.
Can we use the short form for full blood count?
Yes.
And that adding to a number of words as well.
Exactly.
I said something about this.
Now, the assessment includes the mental state exam, and it also includes your formulation. And a lot of people will fail in the formulation because they'll tell me about things that weren't in the history. So, in the formulation, they'll tell me that when they broke up with their boyfriend or girlfriend, they became suicidal and started self-cutting. But that actually needs to be in the history. You need to tell me that in the history. Basically, when it comes to word counts, you're moving it from the formulation into the history section, so it shouldn't make much difference. And in the formulation, you just talk about the traumatic breakup, or how they responded when relationships broke up. And look, mental state exams, it's really depressing to me, the weird things that people think is a mental state exam. I've had people do longitudinal mental state exams, which doesn't make any sense at all. And if you're worried about words, the mental state exam is a statement of facts. This is where you could almost do bullet points. You don't have to give me a commentary. You don't have to explain why someone's dress was dishevelled. You're just commenting that their dress was dishevelled. They were wringing their hands in the interview. Tell me about that. You don't have to say, they were anxious and I knew that because they were wringing their hands. Tell me about wringing the hands and I'll make up my own mind why they were doing it. And again, this is a bit like Agatha Christie. You give me the evidence and I'll put it together. And then in your formulation and your diagnosis, when you talk about anxiety as a disorder or as a symptom, I'll say, oh yeah, I was thinking about that. She was wringing her hands, wasn't she, when you first met her? Certainly in your mental state exam, use the terms correctly. Judgment seems to be a major weakness. Now, when we talk about a risk assessment, there needs to be a good, detailed, thorough risk assessment somewhere in your case, either with your mental state exam or often with your management plan. Doesn't really matter, just as long as there's one there. And we are not talking about the generic risk assessment that you do with an acute admission, 2 o'clock in the morning. Is there harm to self, harm to others, risk to reputation? We are talking about risks of being involved in psychotherapy. How are they going to cope with termination? Are they going to be reliable? How are they going to deal with breaks in therapy? And how do you know that? By looking at what were the difficulties that you told me about in the assessment section. What happened when they were sacked from work? What happened when they were in a relationship that went bad? How do they cope with that? Because what they did in relationships previously is a really good indication as to what they're going to do in your relationship. And maybe what the risk is not something bad like they're going to cut up. Maybe the risk is they're going to put you on a pedestal. Maybe they do that to people. They put them on a pedestal and then they knock them down. And if that's what they've done with previous relationships, that's what they're going to do with you. Those assessment sections are going to be wonderful. You are going to come out of each session for those first weeks feeling great. You know, this patient really likes me, they respect me, they see me as a powerful, important doctor. Discuss that with your supervisor and be prepared when they knock you off your pedestal. Now, the good thing with this risk assessment is you can update it once therapy is finished. So if something has gone wrong during therapy, maybe you can foreshadow it in a post hoc manner. I'm not going to know about that. The other personal bugbear of mine is genograms. People really spend a lot of time doing these really elaborate, beautiful family histories. But more often than not, they're done incorrectly. So I've had a genogram where fortunately it wasn't the patient, but it was a virgin birth. And in fact, it was a virgin birth by a man, which really troubled me. Another patient was living with their dead uncle, which again, I was terribly worried that wasn't mentioned in the assessment section, and necrophilia wasn't a part of the diagnosis. And one genogram, instead of the squares and circles, they did triangles and hexagons. So I don't know what it meant.
Different species.
Yes. So, look, if you've got a complex family history where there are second husbands and third wives and things like that, yes, a genogram may help to explain that. But if you've got a bog standard, grandparents, parents, siblings, a couple of aunts and uncles, it'll just be easy to tell me about it. Don't waste an hour and a half doing a genogram. But if you do one, make sure it's correct.
Like if you have a patient who has a kind of big family, like 10 or 12 siblings, when we are writing about the relationships in the case, do we need to go into every sibling or just the prominent sibling?
No, yeah. So you might say there are 12 siblings, but the key relationships are, you know, first, fifth, and baby.
Yeah.
And give me a little bit about those people. All right, now the formulation. The idea of a formulation is a true formulation has three parts in the literature. The explanatory formulation, etiological formulation, bringing together all of the factors that explain. What they explain is the diagnostic formulation. And there are going to be three parts. The third part is the prognostic formulation. We're not so fussed with this, with the prognostic formulation, but we are with the etiological and diagnostic formulation. And a lot of people want to give me the diagnostic formulation because they think that's critical, and then give me the etiological formulation. And that doesn't make any sense. It's like if you told me who did the murder, I'm not really so fussed about why they did the murder, because you ruined it for me. So if you give me a history and a diagnostic formulation and tell me this person has major depression, I'm not so interested in why they have major depression, because you've already told me that. Much better you give me the etiological formulation, give me all the evidence, and then I'm thinking in my mind, this sounds like depression. And then when you give me the diagnostic formulation, and I read depression, again, that's that single narrative. It all makes sense to me. There isn't a disjunction. So etiological formulation first. As I said, you don't introduce new material into the formulation, but you bring together all the evidence. And the etiological formulation, again, is not a statement of facts, it's an explanation. So you introduce theory. And look, if you want to introduce a bit of Freud, a bit of Jung, a bit of self-psychology, a bit of object relationships, a bit of Erikson, that's fine. This is the place to play around with your ideas, to explain what's going on with the patient. Formulations do also need to consider the biological. Lots of people, a lot of people are on beta blockers. They're notorious for causing depression. And we are doctors, we cannot forget biological factors. Another case was a woman who had a hysterectomy in her late 30s. And that wasn't mentioned in the formulation. And I would have thought that it's pretty critical when you take away a woman's fertility in her 30s. Whether she's got children or not, it's a major change in someone's life. So tell me about all of that. And again, this patient with cancer, cerebral secondaries are a real concern. Tell me about it. Now, when I'm reading a diagnostic formulation, I presume that you know the patient better than me, and you've actually got the diagnosis right. You also run it past your clinical supervisor and your psychotherapy supervisor. So when I say an incorrect diagnostic formulation, that's again this single narrative story. If I'm reading the story, putting all the pieces of evidence together, and I come up with the same diagnosis as you give me, that's the correct diagnosis. But if I'm reading this story and I'm thinking, oh, borderline personality disorder all the way through, and you're giving me evidence for borderline personality disorder, and I read major depression, I'm thinking that's the incorrect diagnosis. Now, I might be blaming the diagnosis when the problem is the history you wrote to me. So, when you fail your diagnostic formulation, it might be that you need to rewrite the history so that you emphasise the depressive illness and underestimate the borderline type behaviours. The other difficulty with the diagnostic formulation is people feeling that they have to give you a diagnosis. Maybe there isn't one. Maybe there are personality traits, and that's the diagnosis. Maybe they don't have borderline personality disorder, but they have some borderline traits. Fine, people are allowed to be relatively normal and not have a diagnosis. But tell me about their personality, and that's your diagnosis.
Can this discussion of personality separated from the formulation put into one discussion of the differential diagnosis?
But somewhere you're going to have to tell me what the diagnosis is. So classically people will give me DSM-5 diagnosis, and here you can actually use just dot points. And then they'll do their discussion of diagnosis or discussion of differential diagnosis. And so what you might say, diagnosis, borderline personality traits, and there might be nothing else. And then in your discussion, you'll talk about how her mood symptoms never reach the level that there's dysthymic or a major depression. Or maybe there was major depression years ago, but now it's depression as a symptom. And she doesn't have borderline personality disorder, but maybe her difficulty is relationship sensitivity, or whatever phrase it's used in DSM. Maybe that's their problem. They're just hypersensitive in relationships. And so talk about that as being a trait, and that's your differential diagnosis discussed.
Do we need to give the DSM points as well?
Yes, it does have to be DSM-5. But lots of people want to give me the code numbers of DSM, and I don't know what they mean. I don't care. They're a complete waste of word count. So just give me the words, the names.
One usually becomes less convinced of the diagnosis as the treatment unfolds.
Yes. And that's wonderful. It's beautiful to see that during the course of the therapy you actually understand the person better. And so that's this is your working diagnosis at the beginning, and your discussion
Written
about
in a post hoc fashion.
well, no, this is why you actually want to write this part after 10 sessions of therapy. When it's fresh in your mind and when you really are convinced this person has major depression or relationship sensitivity. And then during the course of therapy, yes, that understanding is going to evolve, and that's your reformulation.
And if the not offering a diagnosis is the decision to not offer one, that's not going to be uniformly
Look, there's going to be-
accepted.
No.
There'll be plenty of people who won't care for that.
Yes, because I'll be asking, why is a perfectly
Dodgy
normal
choice.
person having therapy?
Yeah.
So there's got to be some reason why they're having therapy, why you think they would benefit from a year of your time. And it might be, a personality disorder. It may be a symptom, but there's got to be some reason why they were referred to you in the first place. All right, so now management plan, I've already discussed. You need to present a model of therapy, and that needs to be justified, and you'll justify that model of therapy from your etiological formulation. Their developmental trauma, their interpersonal sensitivity, whatever it is. And the risks of therapy I've already discussed. The other reason you're going to fail the management plan is you need to tell me about what therapies you put aside. And you actually need to do this in a serious manner. So, what's the evidence base for borderline personality disorder? You need to tell me about the indicated medications and therapeutic modalities and why they were not offered. If someone has borderline personality disorder, why weren't they referred to a dialectical behaviour therapy program? Now, we're not overly fussed on this. We know that you are looking for nice patients to undertake an exercise. And maybe the real reason why you wanted to do therapy with this patient is because it was getting towards the end of third year and thought I'd better get this done. And so that's why you didn't refer them to the DBT therapy. But in this situation, I actually don't want to know the truth. I wanted to know a nice made-up excuse. The person didn't like group work. The wait list for DBT was too long. And lots of people don't undertake CBT in the case reports because the patient really wanted a deeper understanding of the origin of their symptoms. And I'm happy with that. I just need to know that you are aware that there is an evidence base for treating conditions, and you've gone through that evidence base and ticked off no, bingo, dynamic therapy. Now, your management plan, your etiological formulation may indicate that object relations therapy is required, and your supervisor may be experienced in some psychology. You can explain that disjunction by saying, my supervisor were experienced in self-psychology, so that's why we offered self-psychology. And again, that is perfectly understandable. It is not an ideal world. You don't have a dozen different therapists, each brilliantly skilled in different schools of therapy. So again, when I read that, that's not a disjunction, that's an explanation as to why what happened.
If somebody didn't done the scaling, rating scale for the patient, suppose if we are thinking they're having GAD or something else, can we put the rating scales as well?
No, I actually wouldn't waste words on that. I'm happy in your history, if you've given enough history for GAD, and that's what your etiology and diagnostic formulation say, yeah, I'm happy with that.
Sure.
And I'll discuss that during the progress of therapy. Yeah, okay. Oh, your management plan really needs to be specific for the patient. Eclectic therapy is not dynamic. CBT is clearly not dynamic. Supportive psychotherapy. Again, that's not dynamic. And certainly I've had cases where they've said, I'm offering this person dynamic supportive therapy. What that shows to me is complete ignorance about what support and what dynamic therapy is all about. And as I mentioned earlier, the schema therapy is not dynamic. Now, clinical progress. When I read it, I want to know about you and how you changed and grew and learned during the course of therapy. I also want to know about the patient and their symptoms. So if you've got someone with GAD, at least at the beginning and the end, I want to know how debilitating their GAD is. And if magically, at session 20, you realise this patient isn't wringing their hands every time they see me, just mention that. You know, I don't know how long this has been going on for, but at session 20, I realised that the patient was much, much calmer in the sessions with me. She wasn't carrying her brown paper bag with me into the therapy. You know, those little observations are really interesting. The other thing that I want to know about in the course of therapy is your supervisor. You know, what did you take to supervision? What did they say? How did they help you? If you had to do some sessions by teleconference, what was that like? Tell me about it. And again, I don't want glowing reports saying this was the best supervisor in the entire world. Everything they did was perfect. It was wonderfully understandable. Look, be honest. If you only had 30 minutes each week to present, tell me that that was difficult because you were very anxious at the beginning of therapy and needed more supervision and support. And tell me if it was any different at the end of therapy. If you actually felt a little bit more confident about what you were doing. And even though the supervisor was no more available, you know, it was a bit more helpful. If your supervision was on the phone, it is going to be really, really difficult. What's it like when your supervisor actually can't read you and you can't read them? If you did therapy sessions over video conference, what was it like? Is it an exercise that you will repeat or never do again in your life? Because it just wasn't the same as having the person in the room. So it doesn't have to be perfect. Look, and if there are key incidences during the course of therapy, gift giving, boundary violations, tell me about them. If there was a gap in therapy, even if it was just a week, and the patient was different after that gap, tell me about that and explain why you think that happened. Because again, particularly with gift giving, if they give a gift and you actually don't reflect on that in a mature way, then you'll fail all the course. Try and explain from the patient's perspective. What were they doing in giving you a gift? What was going on in their head? And how do you understand it?
Sorry, what if I did a course of treatment? A patient has a hospital admission, like a crisis or something.
Yeah, look, that does happen.
Did that happen to my patients?
Yeah, so look, well, it's up to your clinical supervisor, but my expectation is while they're in hospital, you're not going to do therapy with them. So, what I would hope you'd write about is your anxiety about being away from the patient for that period of time, and your anxiety about what's it going to be like when we get back together again. And if you felt you did something to precipitate this, write about that. And reflect on it and tell me what your supervisor said about your concerns. Again, we're not expecting you to do perfect therapy. We're expecting you to question everything that's going on and try and understand it. And then when the when the patient is better, back home, maybe when the acute care team have finished, their follow-up and you're resuming therapy, then just carry on. And if it was session 20, they're all out of it for 8 weeks, those weeks won't count, so you'll be resuming at session 21. And again, if you take 4 weeks leave or the patient misses 4 sessions, they're not part of the 40 sessions.
Maybe one thing regarding the mental state examination. When we are doing the mental state, writing the mental state examination, is it the first session we are writing?
Yeah, the first session. Yeah, all right. And look, termination is a big thing in the course of therapy. And again, cases fail because at session 38, I decided to tell the patient, we've got 2 sessions left. And when I look at the understanding of the patient and the therapeutic process that's been undergone, again, the image I have in the back of my head is this is a patient who's going to need, almost 20 sessions notice that you're going to terminate. And if you give them 2 sessions notice, I'm really not surprised when they deteriorate and they don't come to your last 2 therapy sessions. Because what you did was really traumatic to them. So you actually need to discuss with your supervisor how to terminate with this patient. Because it's absolutely critical. And you actually want to finish this process on a happy note, where you're happy with what's happened and the patient has dealt with it really, really well. It is not unknown that you're terminating the patient is the first time that they are going to leave a relationship in a successful manner and not be traumatised by it and not go home and start cutting up again. And if that happens, that's fantastic. In the year of talking with this person, you have actually changed their personality. It does happen. But no matter how beautiful the therapy has been, if you were to give that person 2 weeks notice that we're terminating, they're going to go home and start cutting up.
What about spontaneous patient-initiated terminations?
It depends where it happened in the course of therapy.
Well, it happened, in my case, it happened in the end of the second year, with 2 months of termination phase, up to the 70th session.
And when they just sort of stopped.
She wanted to stop. She was ready to stop.
Yeah, and that's fantastic. You can write about that.
It also coincided with the end of university, and she wanted to go to work, and it was very hard to come to the sessions and so on. It was a choice at the time.
Yeah. So you can talk about, the patient taking control of this aspect of their life. Or hopefully you've actually written a case and submitted it by 70 sessions, and so it wouldn't necessarily be an issue.
If that termination of therapy is my supervisor's decision, and in my case, it's my patients actually experience domestic violence, and the husband threatened to harm patients. And so my supervisor thinking towards the end of the 40-section therapy, my supervisor thinking is more complex, and so it's better to refer to community mental health service for continuous long-term psychotherapy therapy.
Yep.
So is that,
Yeah, that's very, very appropriate. And what I'd be interested in is your emotions. How did you feel sort of being forced to terminate at that point? Were you relieved that you weren't exacerbating this sort of situation? Or were you disappointed that you were starting to really enjoy this therapeutic relationship and it was being taken away from you? And has forced ending of relationships like that have happened to this woman's life in the past. So, has therapy actually repeated a trauma that's happened previously? That would be a beautiful observation to be able to make it as true. And at this point, I'm going to start flying through things. But you've all got this talk as a PDF, so you can connect it. Okay, now, again, your reformulation, this really does have to be a junior consultant standard. And you have spent a year with this person, and if you don't have a greater understanding than you did after 4 hours with them, then therapy's counted for nothing. And look, in a situation like that, try and understand the patient in the context of a different model of therapy. You know, what would Erickson say about this patient now in therapy, or something like that. But honestly, you are the single medical practitioner that spent more time with this person than anyone else. You should have a great idea about what's going on inside their head. So tell me about that. That's what a reformulation is. Again, not just a statement of observations. Again, look, give me a critical appraisal of supervision. Or, look, if it was absolutely perfect and wonderful, what were the benefits of it? Where did they really calm your nerves and your anxiety? Now, communication and liaison. Again, going back to the point, you know this patient better than any other health practitioner. When you hand this patient on to someone else, and you're going to at least do it to the GP, I don't want to know I wrote to the GP. I want to know what you wrote to the GP. What bits of your greater understanding of your patient have you given to them? How would you interpret your reformulation in the context of a GP? How are they going to manage this patient? Is compliance an issue? Are relationships an issue? How is the GP going to handle this person in a crisis? What would you be suggesting? If you're passing them on to another psychiatrist or a psychologist, what information are you going to give them to help them to understand the patient and not go through a year of therapy before they were in the same situation as you? And again, the discussion, look, be honest. And, you know, tell us what's been going on, how your ideas have changed, why you didn't like the model of therapy, why now at the end you wish you'd done something differently, used a different model of therapy. That's perfectly fine. Yeah, be critical, be reflective. Okay, so proofread your case before you submit it. Some people are crazy enough that when they get feedback after a failed case, they actually don't respond to it. They don't change anything. They resubmit exactly the same thing. And surprise, surprise, they fail a second time. Was it Einstein that said...
Yes, don't expect new results.
Yeah. You know, something failed once and goes to the same examiner and fails a second time. Surprise, surprise. One thing that bugs me is italicizing. I don't know what that means. That's not, again, proper English. If you're quoting a patient, you put it in quotation marks. You don't italicize it. Very personally, issue is a non-word. Issue actually implies a conflict. But psychiatrists seem to use the word issue as a word that you use when you don't know what word to use. So people don't have depressive issues and borderline issues. And finally, don't be quite careful enough about the liberal use of qualifiers. This can be very annoying, excruciatingly incorrect, such as one case where they made reference to a person having a mild borderline. So, you know, give me facts, don't give me qualifications. You know, very quite mild. That's not helpful. Giving me a score on the scale, yeah, that's helpful.
But it speaks to the imprecision that unfolds from getting to know a patient over a long time.
Yeah, and talk about imprecision. What you understood of their personality traits at the beginning is different to the end. Don't tell me that they only had mild personality disorder. Personality traits, yeah, they can have a minor effect on someone's life.
Use the language, the parlance that we use.
Yeah.
What about using the word I as well?
Oh, yes.
Yes, no, what's
Yes.
the view?
Yeah, you can use it a lot.
Okay, so that's interesting because if you look at most, which I think I agree with, if you look at most academic writing, trained in any medium, of course,
Yeah.
they eschew the use of the word I, for no really good reason, I think. But most all the college journals, international academic journals, if you submit something, I think something, it'll be crossed out immediately.
Yeah.
But I think this is a beautiful, particularly something like the psychotherapy case. I mean, there's a far more honest way about approaching it. I thought this. These are the reasons I felt this. So I think that is important for you all to know. I think what Andrew's saying is that time and time again in this presentation, and other times when you watch trainees perform examinations, say Yoski's or whatever, they're interviewing someone and they can see that something's not quite right. But instead of acknowledging that to the examiner, they look for something that's not there because they think the examiner won't want that. But in fact, that's exactly what the examination is all about. Think about what you're feeling, think about the uncertainty, and then put it in words and explain it to the examiner, which I think Andrew's went to on a number of occasions. So the word I think is very useful.
Yes,
That's good to know.
absolutely.
Thanks, Andrew.
And look, I'm sure you've all done an assessment of a new patient at 2 o'clock in the morning, and you come away from it thinking, I've missed something here, or, you know, I'm troubled by something this patient has told me. We all get those gut feelings. And this is a perfect opportunity to post hoc or at the time write about those feelings. One thing I haven't mentioned is you do need to keep EMR notes on the patient, but most people will also keep separate therapy notes, and it can often be like a personal diary, you know. And certainly when I was doing my patient, at the end of each session, I wrote down all those gut feeling sensations that I had about the patient. And it became less and less during the course of therapy, but it was really helpful to have that stuff when I was writing up my case. Because I didn't remember how I felt at the end of that first assessment session, but I had some notes there to tell me what I was feeling or what I was thinking. All right, there are lots of college resources for you, and if you want more resources, contact your people on the trainee representative committee, and give feedback to the college. We want more webinars. We want more this and that, and yeah, if the college can, they will give it to you.
Or could we just put in a plug the annual case workshop that's run by the Faculty of Psychotherapy locally.
And so that is going to be an annual.
It's been an annual event for like, I don't know,
3 years, I thought.
Even longer, I think. But,
okay.
but it's just keep your eye out for it.
Yeah. Yes, unfortunately it happened 2 months ago. Yeah,
That's
so next year. All right, any final questions?
Do you have like a rough guide as to how many words like each part should take up, or do you do that
No.
different?
I'll often read cases and it's clear that someone's wasted lots and lots of words, but without actually having a case and saying, look at this paragraph, it says nothing. It's been hard. What I would suggest though is never repeat yourself. So again, in your assessment section, if you give me a slab of history and tell me how this person responded to relationships, don't repeat that in the formulation. One, because you'll try and use different words and it will read differently, and I'll be thinking which one's the truth and which one's the lie. But you can then go to your etiological formulation and summarise what you told me in the assessment by talking about traumatic endings to relationships, or her traumatic incident when she was 12 years old. When in the history you've told me about the sexual abuse and what happened when she was 12. So yeah, cut down on repetitions as much as possible.
Can you describe what happens to 3 WBAs? What?
Yeah, you'll get the classic WBA form with comments on it. You'll sign it, your psychotherapy supervisor will sign it, and you'll submit the 3 of them with your PATs.
And so is that the supervisor sitting in with you for 3 sessions then as well?
Yeah. Oh, no, it's your psychotherapy supervisor.
Psychotherapy supervisor. Watching therapy sessions?
Or no.
Clinical assessment and that sort of stuff?
Yeah. So just in your supervision sessions. Yeah.
But can we put in a plug too, that at each of those, don't do the normal case-based discussion where you just do it verbally. Actually, write something at that point, because then there's an authenticity to those narratives when you then come to the end and put the whole thing together. So we squeeze most of our supervisees to cough up an actual written formulation, front part of the case, the middle,
Okay. Actually, yeah, look, that's probably a good discipline. So you're writing as you go. So
It doesn't mean that you don't change at the end because you want that big reflective.
Yeah.
There's something authentic about.
Yeah, the different phases. Yeah.
If we have done session of the weekend or the after hours, do we need to mention that one?
Yes, yeah, because that's an absolutely fantastic, unusual thing that happened in the course of therapy.
But is it allowed to do that?
Yeah.
Yeah, I met one patient at 7 o'clock in the morning.
Yeah, and I'm really interested in why.
She had to go to work.
Okay, so how did you feel about that? Tell me about that. What was it about? So did that impact on the relationship? Did you feel duty bound towards the end of therapy? Were you getting really tired?
We agreed to do it for a
regretting
certain
that you had agreed to that?
No, because we agreed to do it for a circumscribed period in the abstract.
Okay.
That's fine.
Yeah. So something interesting and unusual to talk about. And if it was a single episode on a Saturday, yeah, tell me what were your emotions about that? What were you frightened about? And if you've read anything about boundary violations, they often start with simple things like seeing someone after hours once.
So there's a
and then it ends up with having dinner together. So talk about why did you do something unusual like that for your patient? Was it anxiety about if they didn't do it, they'd drop out of therapy? So were they blackmailing you? How did you feel about being blackmailed? And that, you may not come up with those ideas until you discuss it with your supervisor. And they'll be saying, why did you do that? What's going on? What are your emotions about it?
How deep are you analysing yourself? Are you just sort of talking about your emotions towards things, or are you explaining?
As much as you want to. Okay. Look, some of the cases, there's more about the registrar than there is about the patient. And they're almost an afterthought. And those cases will still pass, as long as there's enough of the patient. But if there's a lot of reflection, then great. You have reflected on what went on.
You have a limit as well.
Still the same 10,000 words.
Any final questions for Andrew before he heads back?
That 10,000 words is very strict.
Unofficially, you've got 10,500 words. So, look, up to about 18 months ago, it was absolutely 10,000 words. And if you submitted a case, as happened, 10,001, 10,002 words, it will be an automatic fail. And something like that, and de-identification, you get no feedback, and it's your first submission. So you really want to de-identify, and 18 months ago, you didn't want to go over the word limit. But if you do 10,100 words, 10,200 words, that'll still go to the marker and be marked.
But you will not.
I don't know what the thing is.
There's a waste of being
Yeah, but look, if you go 10,010 words, don't try and find 10 words that you can't. Don't worry
They
about that.
they can change the rule. That's the main thing. The rules change.
Look, we haven't publicised that already, so you're going to be safe. And for that, you can actually quote me.
Can we, you
Everything
are
is
safe.
on the
You can have that bit in the beginning.
But could we just please thank Andrew for making the and thanks for turning up. And any individual questions, have a chat to me, your supervisors. I'm sure I can have a chat to Andrew if I don't know the answer. So I'm along the way.
Look, at any time, you can also email the college, saying, look, I have this question, I don't know, my supervisor doesn't know. And the college officer will send it to the right person, will send it to me, and I'm happy to respond to things like that.
Excellent.
Yeah.
You after such a, we spoke over the phone.
I guess my something.
Yes, I know you were.
I'm sure.
How's it all going?
I was very interesting.
If you do want to talk to me.
Yes.
So the most important sort of issues around that.
Yep, okay, it's going to start in
Very surprising. Intensely scathing.
Yeah, I know. Now I know. But I feel you are similar. I know that day in that first they say writing, I know they completely.
To the also is appreciate the Thank you very much for your support. Thank you. Thank you very much. Happy fellowship. Happy
Don't be afraid to start.
I really appreciate it. It's in the middle of this side.
Yeah.